Hello, everyone. Welcome to part 2 of CATA's special 3-series titled There's Always Evidence. I'm Nicole Mittman. I'm the Chief Scientist and Vice President of Evidence Standards at CATA. I'll be moderating today's webinar. I just wanted to acknowledge that today I'm speaking to you from Toronto, Ontario, Canada, which is on the traditional territory of many nations, including the Mississaugas of the Credit, the Assiniboine, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many First Nations, Inuit, and Métis peoples. I want to acknowledge and thank many of the generations of people who have taken care of this land, and to think about and encourage you to think about the land where you're on now, and for the people who have been the stewards of this land and our shared responsibility to preserve and protect the land for future generations. So I started out by saying, welcome to the series. But I'm sure many of you, it's actually welcome back, and I'm hoping that's the case, because you attended part 1, with our great kickoff session and presenter, Dr. Gordon Guyatt. Taken as a whole, the series is really being used to identify evidence sources that can be used to inform decisions when the gold standard evidence from randomized controlled trials is not available. And not just pointing them out, but highlighting how they can be used. In today's session, we'll look at the unique value and benefits of using observational and non-randomized studies to inform health policy, decisions, and practice. We have 2 speakers today who are going to share their insights and experience with this type of evidence. So I'll first introduce Amanda Sheppard, who is a scientist in the Indigenous Cancer Care Unit in Ontario Health. Dr. Sheppard's research interests have focused on elevating health and well-being within the Indigenous populations. She's an assistant professor with the Della Lana School of Public Health and the Division of Epidemiology at the University of Toronto. Our second presenter is Sehar Jamal. She has more than 5 years of experience working in the public sector, particularly focusing on cancer systems and the community experiences of cancer, while using qualitative data, as well as looking at large and small cohort data. So from a format and perspective, before we get started, let me go over a few logistic items. Today's session is mostly going to be didactic, although there will be some opportunities for polls, answering polls, as well as a question and answer period at the end. Feel free to submit your questions anytime using the Q&A button or the tab at the bottom of the Zoom control bar. But just be aware that we'll hold all questions until after the presentations. You can also use the chat tab to share observations and comments and relevant to the participants and to the audience. And I'll rely on my CATA team to help me organize the chat functions as well. And so with the help of Michael, Raj, and Don Servo, I'll be monitoring both the chat and the questions. And we'll get through as many of the questions as we can in the time allotted. So thanks very much for for asking questions along the way. And finally, as a reminder that this session will be recorded and will be available on CATA's YouTube channel later on this week. And on that note, let me turn things over to Amanda and Sehar. Thank you.
Thank you for that, Nicole. I'm just going to queue up our presentation. And here we go. And actually, Sahar is going to start. I'll hand it over to you, Sahar.
Great. Thank you so much, Nicole and Amanda. So today we'll be able to talk to you a little bit about how we're going to be able to use observational studies and really using that to make decisions in the healthcare system. And so Amanda will just be advancing the slides for me. So maybe next slide, Amanda. Do you want to do your disclosure?
I'll just let folks read it so we can save more time for Q&A.
Sounds good. So then same for me, no disclosures here.
Okay.
So why don't we get started in the next slide? So the goal today is really to talk about the different observational study designs. So as Nicole mentioned, the initial part of the study, the presentation is going to be mostly didactic from, just refreshing your memories about what the different study designs are, what association and causation has to do with the literature, any biases that may come into the picture. And then Amanda will then go forward and talk to you more about the tools that you can use to appraise this information and inform health decisions. Next slide. All right, so just to start off, we want you to forget about experiments for now. I know that everybody's probably quite familiar with RCTs, randomized control trials, especially within the pharma space. But here we want to talk more about observational studies, where we're focusing on observing the effects of an exposure without any form of intervention. And why do we want to do that is because oftentimes there are ethical problems. You know, if we're aware that something might be harmful, we don't want to expose people to that willingly. And so this is where observational studies tend to really shine and give you a population level picture. Next slide. So we'll start off with cross-sectional studies and then go into cohort and case control. But cross-sectional studies, everybody's probably seen the health surveys like CCHS, the Canadian Community Health Survey, where you're essentially measuring the prevalence of an exposure and outcome, and it's at one given time. So you kind of, the weakness there is that it lacks temporality. You can't really say that the exposure came before the outcome because you're measuring that at one specific point in time. So it is generally used for a prevalence method as opposed to assessing risk of something. So next slide. So cohort studies, I'm sure you've heard of as sort of being one of the studies that you can be more confident in. And it's essentially one where we're following people over time to develop a disease. So we generally start with people who don't have the disease, and then we can classify them. If Amanda goes to the next slide, you'll see a really quick diagram that you have a set of people that are defined in the population, and then you kind of put them into categories of whether they're exposed or unexposed. And then eventually over time in the future, you'll be able to determine whether that person from the exposed category was diseased or the unexposed category was diseased and vice versa. So here we're just trying to figure out over time whether this person or people develop the disease. So if Amanda goes to the next slide. Generally, because we are starting off with the exposure and then it will result in an outcome in the future, you'll be able to calculate a relative risk. So relative risk is for cohort studies where the equation is essentially looking at the disease in the exposed group divided by the disease in the unexposed group. And that essentially tells you the risk is X times higher or X times lower from the exposed to the unexposed. And with relative risk, you get that number, the ratio. And so anything that's less than 1 is considered lower or protective risk. Anything that has 1 in it means that the risk between the exposed and the unexposed are pretty much the same. And anything greater than 1 is generally the risk is higher. And so you don't really want to rely on just one number. And for that reason, we calculate confidence intervals. Which essentially give you a range of the relative risk. And so then you can be about 95% confident, assuming the level of confidence you're looking at, that the true relative risk is within the range, right? So you'll be sure that if it's 1.5 to 1.8, you know that the true relative risk lies within those. And anytime the confidence interval includes 1, so if it's 0.8 to 1.5, we know that there is a potential chance that the risk is not statistically significant. So cohort studies, I'm sure you've heard about, and one that I think is particularly interesting to follow given the times of COVID is the Canadian COVID-19 Prospective Cohort Study, or it is called CANCOV, I believe, led out of a researcher from BC. They basically want to look at the impact of COVID across the year. So what the outcomes will be a year from now, for example. And so what they've done is they've developed a cohort wherein 1,000 people will be COVID cases that were hospitalized, diagnosed in the hospital, and 1,000 that were diagnosed in the testing center. So you can see that the aggressiveness of the COVID might be different. And then they want to follow these people over time and measure their blood, genetics, their healthcare utilization, their quality of life. And they want to see how that is different among the two groups. And they will be able to have an answer or some sort of associations that they can deliver to us within a year or two from now once the results have been released. So really a strong study type. And we'll go to the next slide. So that was what I described as more so prospective cohort studies. We also have retrospective cohort studies where in the present time, you have a group of people who you know that they might be developing the disease or they're on their way to develop the disease and they have different exposure categories. And then that's the present time. And then you know that in the past, if you look, you can look at the level of exposures they have. So this design is really helpful for occupational studies where you have a group of people who might be developing certain diseases based off of occupational hazards. And then generally their exposures have been recorded in the past by their company in terms of, you know, if you're a factory worker, you might be exposed to this level versus if you're an admin person, you may not have as much exposure to it. And so your outcomes will be different. Another way, the study design has also been used in COVID. So there's a study done in Ontario long-term care homes where we know that a lot of Ontario long-term care homes have been hit pretty hard by COVID. And one of the bigger issues is because of the crowding within the nursing homes. And so there's a retrospective study done that looks at, they want to assess the mortality based off of the crowding. So what they've done is they've picked different long-term care homes, they picked different long-term care homes, and they're going back and looking at when COVID initially started to a few months afterwards, and they'll look at administrative data to see what different factors can impact their the mortality within nursing homes and how the crowding varies between nursing home and can have an impact. Next slide. So that was cohort studies. Let's shift more to case control studies. And that's the last study design that we'll be chatting about today. And in case control studies, we're basically identifying people who already have the outcome. So those are the cases. And then we're comparing them to people who don't have the outcome. So these are the people that are called controls often. And you want to make sure that you're using case control studies often for rare diseases, because then you don't have to wait for the person to develop the disease as you would in a cohort study. Here, the person already has the disease. And so then you can look at their exposures within the cases and within the controls. And of course, you want to make sure that the controls are also people at risk. So for example, you wouldn't be including, if you're looking at a study about dementia, you wouldn't really be including a child as a control because their risk of dementia, developing dementia is very different. So next slide. Just a really quick diagram. I think that it's always helpful to have some sort of illustration. So literally to show you that there's a group of cases, controls, and then we're kind of figuring out among those who's exposed, unexposed, and same with the controls. So next slide. So here, because the outcome has already been developed, the outcome has already arrived, unlike a cohort study, we're going to use odds ratio instead of relative risk. So we're going to look at the cases, the odds of the cases with the exposure and without the exposure over the odds of the controls with the exposure and the controls without exposure. So I want you to just remember the difference between odds and probability. So previously in the relative risk, we were looking at sort of the probability of getting the disease over all other outcomes, whereas in odds, we're sort of just getting the probability of getting the disease versus not getting the disease. And again, we want to look at confidence intervals would be the same for odds ratio as it was for relative risk. And again, I'll just share with you a really quick example of a case control study that's done in the COVID realm, just kind of being on theme. So we've heard a lot about ethnicity playing an impact on getting diagnosed with COVID. So there's a case control study that was done that looks at cases being people who were diagnosed with COVID in a hospital in an inner city, so within a specific region. And then they're essentially finding people randomly who will be controls, who don't have the disease, but also live within that region. And they're kind of matching them on age and things of that sort. And they found out from that essentially they noticed that people that were of ethnic backgrounds tended to get COVID at a higher rate. So they're a higher risk of getting COVID compared to non-ethnic folks within that same inner city region. So this is kind of really important to figure out what different aspects can impact your risk, especially if a lot of the other aspects are controlled. So next slide. So we've talked a lot about different study designs, and this is just to show that there is some level of hierarchy of evidence. So this pyramid doesn't consist of all the study designs. There's tons out there. But just to show you sort of at the bottom of the pyramid, we have editorials and expert opinions. And then we have case series, really helpful for clinical examples. And then we have case control, cohort, randomized control, and systematic reviews where we're sort of looking at a pool of results. So one thing really important to notice for the hierarchy of evidence is that, you know, while this may be the levels, you want to be mindful of the study designs and how well the research was done. So for example, there will be many studies out there where you'll see the case control study that's really well defined and well controlled and designed compared to a cohort study that's not as well designed. And so in that case, you would actually might want to consider putting more weight on that case control well designed study as opposed to the cohort study. But this is just sort of like a little framework to think about. So I think for next we have a poll, if I'm not mistaken. So if we could just pull the poll up. Yeah, so here I just want to, there's an example of a study that I'm interested in doing. So what kind of study would you use if you wanted to look at the effects of using probiotics during pregnancy in the first year of life? Would it be cohort, case control, or cross-sectional? Maybe I'll give everybody a couple of seconds to fill in their answer, and then I'll let the CADIT folks show us the results. All right, cohort. All right, so it seems like everybody, for the most part, would do a cohort study. And I think that makes sense for the most part because you want to look at the first year of life. So simply you can find somebody, pregnant women, and follow them over time until they give birth and have their child until they turn 1 year old. There's a lot of studies that have been done in maternal health that use that format, which really gives you an in-depth understanding of start of pregnancy until birth as well, what the outcomes will be. So we'll go to the next slide, Amanda. All right. So we've talked a little bit about the study designs. Now, with those studies, when we're reading those different studies in journal articles, what are we looking for? We're mostly looking for an association. We want to know that an exposure is linked to an outcome, and we want to know that that linkage is not because of chance. We want to know it's because of the exposures, specifically leading to that outcome. So we'll talk a little bit about that. So in experiments, you can sort of do more of a causation because you're sort of putting in the intervention and taking it out so you can see the effect. But whereas in observational studies, we're not really interfering that much. So it's kind of harder to just imply causation. So we want to make sure that we can get a really good and strong association to be confident in the results. So the next slide is basically one that will walk through a criteria that a lot of epidemiologists tend to use to think about, just to keep in the back of their mind when they're reading different studies, to think about how strong the association can be for that specific study. So I'll walk through these different criteria. And in the future, when you're looking at different studies, just think about these and see if you can understand better and relate more confidence with the association that has been outlined within that study. So one of the things, and this is in no particular order, so one of the things is strength or the effect size. So generally we've known that the higher the magnitude of the phenomenon, the more likely that the stronger the association will be, right? So often the relative risk, if you see a relative risk of 4, you're like, wow, this is a really strong association. But I want to also be mindful that a lot of the times we do studies where the relative risk is actually relatively small. Like it'll be 1.2 or 1.3, but the clinical impacts are very big. And so you really want to be mindful of the context when you're interpreting the strength, but it is generally a good indication of the association. Then we have consistency or reproducibility. So basically, if anybody can reproduce the same results that you're doing, so essentially redo what you've done and find out that the results are the same as what you've done, then you're more likely to assume that it is the specific exposure to outcome association as opposed to chance that you're getting that So really important to have that. That's why it's really important in literature to read a bunch of different studies doing the same, looking at the same exposure and outcome, just to give you an understanding that yes, in different regions, different types of people, you found the same result. Then we have specificity. So specificity is, the more specific your population or the site or the disease, the more likely that the outcome is because of that, as opposed to a random chance. So, when you're reading different studies, you often see that their interpretation are very specific, right? So it'll be a person within this age group, within this sex, within this region of Canada, wearing this color shirt or this color hat, is going to have this outcome. So they just want to make sure that when they're interpreting it, it's the specificity is accounted for, which will then result in a stronger association. So next slide, Amanda. Number 4 is temporality, and something that we hit right in the beginning. So we want to make sure that the exposure comes before the outcome. And so that doesn't happen in cross-sectional studies. So it's not, so that would be one of the weaker study designs for any sort of strong association. Then 5, 6, and 7, the biological gradient, plausibility, and coherence. So basically you want to make sure that whatever association you're seeing has some sort of logical explanation, like a biological explanation. So something that's often done with smoking and lung cancer would be like, we know that you smoke, it goes through your throat, trachea, and then it goes into your lungs. So there is a biological mechanism that could explain the association between smoking and lung cancer, or smoking and any sort of other lung diseases. And also we noticed that the dose response relationship, so anytime you increase the amount that you're smoking, your risk of lung cancer, for example, will increase. And then last is experiment, which I think all roads lead back to RCTs sometimes, but essentially if you can actually remove your outcome, you remove the exposure or the intervention and look at the outcome, and if it's different and you put it back in, the exposure, then you can more confidently say that the outcome was mostly because of the exposure. So next slide. So we've covered a lot of ground. We've talked about the different study designs and when to use them, what they're good for. We've talked about how we can have some sort of strong associations interpreted from observational studies. And then lastly, really quickly, what I want to touch upon is possible explanations that can impact observational studies. So things like biases, right? So there's a chance that when you do your study, that your outcome is mostly because of chance. It was just a random error. Or it could be other aspects, external aspects that led to your study during the design process or after that hindered your study or biased your study. And so there are different types of biases. I've just listed a few, and within them, actually, there are even more sub-biases, lots of names and terms to remember. But I'll start off with selection bias. So selection bias is essentially when you have a systematic difference between the participants when you're doing a research study. So you've probably heard that, when you do a study with volunteers only, volunteers tend to be a little bit different than somebody else in terms of participating in a health study. They're a little bit more conscious about their health to begin with. They'll be more aware. So their understanding might be different than somebody who never really goes to the hospital or visits the healthcare system. You can also have selection biases where you have two different participants or groups of participants that have very different risk profiles, right? So that will inherently skew your results as well. And so overall selection bias will then impact the generalizability of your results. Then we also have informational bias, which is, again, a systematic difference, but more so in how the data is collected. So here, you've probably heard of the term recall bias, for example. You want somebody to think about what they'd eaten for breakfast 6 years ago. Obviously, there's going to be some sort of memory recall issues when they're answering that. So you have to be mindful of that when you're interpreting it. Or, for example, if you're wanting to calculate body fat, you could use BMI, which we know there are some challenges with that, especially with the muscle and fat dispositions. Or you could use a body fat caliper, which will give you a different type of instrument to calculate the same thing. So just things to think about when you're looking at different research studies and how people have potentially let bias in or how they've tried to avoid bias. And then the last bias that I'll talk about is confounding bias, which is something that we're essentially trying to avoid. We're trying to eliminate. No, Amanda, you can go to the next one. Thank you. We're trying to eliminate confounders within our study. And so confounders are essentially, you need three things in order to be a confounder. So the confounder is a third variable, so it has to be associated with both. So in this case, if we're looking at alcohol use to heart disease, we know that smoking has an association with alcohol use in terms of oftentimes they're used together. And we also know that smoking can impact your risk of heart disease as well. So that's a check. Then the second confounding factor is, so the confounding factor must be distributed unequally among the groups. So if you have two groups of people, if they both have the similar level of smoking, then it almost cancels out. But if you have one group that is more skewed to a lot more, like 75% of them are smokers, whereas only 5% are smokers in your other group, that will skew your results because we know that smoking plays some impact in this alcohol-heart disease relationship. And the last one is that the confounding factor cannot be an intermediary step in the pathway. So in this case, alcohol use doesn't necessarily cause you to smoke. So we're good here. But if we were looking at like cholesterol or HDL, we know that alcohol use can impact your cholesterol level, which can then impact your heart disease. So in this case, something like cholesterol or HDL wouldn't be a confounding factor. So, we've talked about a lot of things. We have just one really quick poll to do before we switch over to Amanda, and she'll explain a little bit more about how we can use some of this information to appraise the study. So maybe we'll pull out the poll really quickly. Thank you. So as part of my research, if I'm asking someone about their sexual history, what kind of bias is most likely to occur? Is it selection, confounding, or information bias? And I'm sorry, there's a typo there. It's meant to say selection. So I'm gonna wait a couple of seconds and then maybe have CADIT folks release the results. Information bias, yeah. So generally it is called the social desirability bias. As I mentioned, there are a lot of different names, but oftentimes if you are confronting somebody with information that might be controversial or they want to appear a specific way around that person, they might be hiding their sexual history just to appease the society. So I'll leave it at that, and then I'll pass it over to you, Amanda, to continue.
Okay, thanks, Sahar. Great job. All right, so we're going to change gears a little bit, but don't forget all the information that Sahar shared. And we're going to talk about critical appraisal. So what is that? It's a process of systematically examining research evidence, and it's to assess its validity, result, and reliance before using it to inform a health decision. So there's pros to doing that. Some of the pros are that there's a systematic way of evaluating the evidence. One pro that I think should be weighted to the highest is it contributes to healthcare by closing the gap between research and practice. So unfortunately, the great majority of research never translates into practice. So doing a critical appraisal and getting that information out there would assist healthcare providers in getting the knowledge. It's also logical to do. Some of the cons, however, I'm just going to move this little box out of the way. Some of the cons can be time consuming, but I promise once you get the hang of it, after a while, it does go smoother. Another con may require persistence with a topic where information is limited or hard to access. So for instance, some older journal publications may not be as easy to access, or if it's a topic that hasn't had a lot of attention, or if the publications aren't in English, if that's the language that you're doing your search in. And then also, it does not always provide a straightforward answer. So if you keep in mind that hierarchy that Sahar shared, there's no straightforward correct result. So you still have to think and judge for yourself, which is kind of the exciting part. So just thinking about critical appraisals, so consider that it's systematic. So ideally you have a relevant tool. So what tool do you pick? Well, there are a lot of tools and I'll present a couple to you, but you really want to think about what methods the paper are using, and that's how a lot of the tools are, you'll see in a table in a moment. That's how they're selected. And then also, and I want to spend quite a bit of attention on this, is what is the research question? And I think that's really important and really sets the pace for addressing all these other things. So let's try to have a little bit of fun. I wanted to come up with a couple research questions to discuss with you, and I'm sure, like you, I was feeling a little tired of looking at my screen all the time, and I just didn't want to read any more articles than I needed to. So what did I do? I surveyed the folks in my household. So I asked them each to give me a research question that related to health in some way. So I didn't bias them in any way, and I didn't probe them. So this is their words, and here we go. So my 8-year-old's question: why don't we have as much fur as pets do? Okay, I thought this was a really good question. It kind of took me by surprise. I didn't really realize it was related to health, but to her it was, so we're going to use it. So if you look at the question, so what could the outcome be? It could be something like the number of hair follicles per area of skin. If you think about the sample, it could be humans around the world, or it could be the members, the humans in our household. In terms of exposure, being a pet, or I think she was probably referring to our new pet dog. So how would you study this? What study design would you use? Well, I think I would probably go with the case study, which is more of an in-depth understanding of one particular case. So we could really examine the differences between our pet and ourselves in terms of our fur, levels of fur. The next question was posed by my 10-year-old. And my 10-year-old always tries to please me, and she knows that I spend my days doing cancer research. So her question had to do with cancer. And she asked, does having cancer make it easier to get COVID? So interesting question as well. So here the outcome would be a positive COVID test result. Sample, we could do adults in Toronto. That's where I'm calling in from. Exposure here is cancer. So a study design, we could possibly do a retrospective cohort design. Okay, next I asked my husband, and he shared, is it bad for your brain to sleep next to your phone? Something that I guess he's concerned about. So question's a little vague. So in terms of the bad for you, what are the health outcomes we're looking at? Is it headaches? Is it a cancer tumor? So that would need to be decided. In terms of the sample, would you want to do the assessment among adolescents where there's possibly more brain development occurring, or would you just pick an adult population, or maybe you would stratify by age and see if there's differences there. And then in terms of the exposure, I think this is the real tricky parts, because it could really vary. It could vary by phone, potentially phone model. It could vary by how far apart where you put your phone is to your bed, so that distance to your head, I suppose. And then also the length of exposure, how many hours a night and how many years of exposure are we looking at? So for this particular question, I think the study designs can really vary. You could do a prospective cohort, and that maybe would help reduce recall bias. I was thinking this might be a good candidate for a mixed methods and having a qualitative component, because I bet there will be a lot of really intimate details about, phone placement and how many times a night the person wakes up and brings the phone closer and puts it away, and all those sort of real life experiences. But if the outcome that we're really interested here is the cancer tumor, then maybe we would do a case control design. For fun, I I didn't ask my dog, but I put a question in that has just been circulating in our household because we have this puppy, and all I hear about are grain-free diets, and I don't know if that's a good way to go. Maybe someone could put the answer in the chat box, but my question is a grain-free diet healthier than a diet with grains? And we don't need to go into detail to discuss this, but I was thinking in practice, this might be hard to control because, you have your meals that you feed your dog, and that might vary 1 to 3 or more times a day. But observing my household, there's a lot of snack giving on the side or under the table, so it'd be really hard to sort of control that, not to mention the bits of bread out in the neighborhood that some folks leave for the birds that my dog seems to find. So what I did was I thought I would move with my 10-year-old's question, and I actually can't see the top of this, but I thought we could spend a bit more time here. So do pre-existing comorbidities increase the risk of death after a COVID-19 diagnosis? So maybe a bit more of a scientific way of framing the question. So we would potentially pick adults with chronic comorbidity, but even that term comorbidity, having multiple health conditions, there's such variability to just that aspect alone. So what conditions are you counting in your list of comorbidities? I know in Ontario at the Institute of Evaluative ICES Service the Sciences, I know that there are several tools to assess comorbidity, Charlson Index, for example. And then do you want to include a tool that also includes psychological conditions if you're concerned about maybe different treatments affecting what your outcome is? Here, the exposure would be the infection, and then our outcome is death. And thinking about how new COVID is in our society compared to other viruses, for instance, do we have enough follow-up time to really make meaningful conclusions? That's something to think about. So for that example, you would turn to the plethora of critical appraisal tools. There are dozens out there. What I did to narrow them down is I thought I would go on to ResearchGate, which is a networking social networking online platform where researchers can ask questions and post their work. And I just, in a non-systematical way, just saw what critical appraisal tools I saw come up more frequently. And these were the 3 that I saw. So the JBI checklist, CASP checklist, and the Strobe checklist. And as you can see here, I just, to give you the visual, wanted to summarize what types of studies these different tools can assess. So if you were really interested in an economic evaluation, for instance, then you would probably use the JBI checklist. And then Strobe has this conference abstract checklist. So again, that might determine what you're looking at. CASP, on the other hand, that's something I've actually used with students, so I was more familiar with that. So I thought we could use that tool to just discuss critical appraisals. So in the example that I created based on my daughter's question, I thought that would be best addressed as a cohort study. So this is the CASP checklist for a cohort study. So once you decide which study type you want to use, then you would just click on that specific tool. So what I like about CASP is no matter what the study design is, there's 12 questions, and it's pretty straightforward to use, and I'll show you that. But basically what it addresses, and if you remember my definition of a cohort, of a critical appraisal, so it addresses the validity, it addresses the result, as well as the relevance. So here we are. This would be the first, so section A, the validity, and then there's a couple questions, and we can go through these together. But just to highlight again, this CASP tool I find very handy because the question is very clear. It's just pick a yes or no, or I can't tell, but then it has the hints along the side. So some of the tools are a bit more daunting because you'd have to then open another document to see what the definitions of these questions are and how to evaluate them. So I do like the ease of this. So did the study address a clearly focused issue? Was the cohort recruited in an acceptable way? Yeah, and again, I can't see the very top of this bar, sorry. Sorry, I can't see the question number 3, but something about minimizing bias because we don't want bias. Question number 4 was the outcome. Number 5, did they consider confounding? Number 6, was the follow-up of subjects complete enough? Was the follow-up of subjects long enough? So as the example I was just giving with COVID, you know, if it's only been introduced into a Canadian context for roughly a year, is that sufficient time? And then the next section B, number 7 is what are the results of this study? So, and again, lots of things to think about. How strong of the association? These are things that Sehar described. So you would take that knowledge and really think it through here. How precise are the results? So again, more narrow the confidence intervals, the more precise the result, and the more. Number 9, do you believe the results? You know, do you think that the result is due to bias or confounding? And then here we see the Bradford Hill criteria come up. So again, thinking about does it really make sense? Is this something that we would see a dose response relationship with? And then finally, section C, will the results help locally? So this is, you know, does it apply to the population that I'm interested in, or the age group that I'm interested in? So can the results be applied to a local population? And again, lots of things to think about. Do the results of the study fit with other available evidence? And then number 12 here, what are the implications of the study for practice? Okay. So I think that this particular tool really does, in a simple way, go through a lot of that content that was described earlier in the presentation, and allows the reader to pretty quickly, once you get the hang of it, go through and assess if it was a paper that you want to consider the knowledge from. And speaking of knowledge, knowledge translation is so important. I mentioned earlier that a lot of research doesn't get translated into practice, into interventions, into use. So how to do that effectively if there's something that you really want to share. And I think it's a combination of who the audience is you want to target and then the resources that are available to you. So if the audience is the public, maybe it's through social media or hosting an event. Again, it depends, but there are could pay for a Super Bowl commercial. I think that's what's going to be happening next weekend. Instead of the traditional commercials, some of those funds are going to be going into health education. That's what I learned from my husband. And then another audience, peer groups. So these tools are actually really great for journal clubs, or you could bring to your community of practice. If your targeted audience are policymakers, try to figure out what they read. Where do they get their information? Is there a conference that that specific group goes to? And maybe you could present there. And there are associations. If you're trying to communicate a message to, say, nurses, you could find a relevant organization there. Another good opportunity is instead of writing a whole paper, you could send a letter to the editor of a journal that you think would have a good impact factor. And one thing that I'm doing right now, there's a research study that is going to have a lot of findings. There's a lot of research questions embedded in the data that we have access to, and we're considering approaching a journal and asking to take over a whole issue, which I think would be exciting and a really great, strong tool for someone who's interested in that area. Okay, so things to think about, and I hope we really whet your appetite with all the practical information that Sahar shared, and then me showing you how to use it in terms of a critical appraisal. What we were planning for the next session is to put it into practice with the real-world topic of your choice. So we'll give you a couple options, and we'll send out some papers in advance, and then we'll critically appraise them together. So it'll be a lot more of an interactive session next week, and there'll be some optional homework for you too. Okay, so could we have the final poll, please?
We're just waiting for the final poll, just a moment.
Drum roll, please.
Drum roll, please. Oh.
Well, as we wait, if I recall the topics that we came up with, we wanted to give you the opportunity to pick, again, another COVID-related paper, and maybe we'll do, if that's the selected option, maybe we would do something other than a cohort study design. I remember the second option was related to sprinkles, which was medication for children developed at sick kids. And the third option was...
Yeah, we're having trouble loading the poll for some reason, Amanda. So should we just make an executive decision and say we're going to do a COVID example? Although the sprinkles one sounds good over lunchtime. But can we, I think if folks are interested in doing that, maybe put it in the chat function. I think then that would be great.
Sounds good. We'll try to find something interesting, a new twist.
Perfect. Okay. So thanks very much for that, both Amanda and Sahar, and very thoughtful sort of structure to the way that we should think about observational studies and potentially how to evaluate their quality. There's been a very active chat box conversation back and forth. I wonder if Like some of the, for example, some questions were very specific around drug technologies, and this is really a methods discussion, so we won't get into specific drug technologies. But I wanted to highlight some questions around methods that we've been seeing in the chat function and the Q&A. For example, in one of your slides, you showed that some critical appraisal tools can also be used to assess qualitative papers. Can you provide some examples of what would be captured in those kinds of tools?
Sure. So again, if we were using the CASP, it would still be the same 3 areas and again, 12 questions. There would be questions again on the design of the study, making sure that the population that were included were representative of addressing the research question. But I think something that you would see in the qualitative critical appraisal tool would probably be more on if the researcher really assessed if with their relationship with the participants, making sure that maybe in a interview setting, doing the data collection, there weren't any biases. So because of the methodology, it's a bit more intimate. So I think that would be something that the author would have to communicate in the publication that they thought of and addressed any ways to eliminate bias.
Thanks for that. We have another question around that is, are cohort and case control studies appropriate to assess comparative efficacy between drugs? So we usually see that in a randomized control situation. What are your thoughts on this?
Well, I think what we're trying to convey is, yes, randomized control trials sure do serve their purpose, but there are a lot of subtle things like ensuring that the participants really represent real-world populations that I think, for instance, a cohort study could really shed a lot of light on. So I don't know if cohort and case control studies would be, sufficient standalone, but I would love to hope that their information would be considered with a lot of weight. Do you have anything to share, Sahar?
Yeah, I was just going to add to what Amanda said. I think they work really well in tandem with RCTs, just as Amanda mentioned. It is important to account for other factors in real life, like whether you have other conditions or different drugs you use, or different regions you live in, and accounting for those and how that can impact the efficacy over time. I think the time aspect that comes from cohort study also will be an advantage to measuring efficacy for drugs.
Mm-hmm. And I'll just make one more comment about that as I'm thinking. Sahar had mentioned earlier about trying to have a more inclusive population in these studies and allowing people from all different communities to participate. So I think in cohort studies where there's usually a wider net, there's an opportunity to get information about a wider range of people.
Thanks very much. Sahara, I have a question for you. Can you clarify the difference between a case control and a retrospective cohort study? Are they both looking backwards?
Yeah, that's a good one, and something that always stumps me as well. I think what's helpful for that is really understanding that when we're doing a case control study, for the most part, we already have the disease. We know what the disease is, and we're sort of looking to find the exposure. Whereas in a retrospective cohort study, believe it or not, we're still sort of looking for that disease. We already know the exposure to some extent has happened in the past and has been recorded in the past, but the disease doesn't necessarily mean, but it doesn't necessarily mean that in a retrospective cohort study that the disease has been developed. You just have a group of people that may or may not have the disease or may be more prone to having a disease. So you're studying those people, like the occupational example that I provided, and then going back to look at the different levels of exposures. I hope that clarifies it a little bit. I don't know, Amanda, if you'd like to add anything either.
I thought you did a great job, Sahar.
Thanks very much. Can I ask about bias? So one question was, you talked about bias, and I'm wondering whether there are ways that researchers can control for bias during study designs or in the analysis phase.
Yeah, so definitely you can control for that biases as you're designing your study. So in those instances, you would be looking at things like matching. So you want to make sure that one group is similar to the other group on a lot of the different characteristics. Aside from the exposure, of course, you want to try to randomize the different characteristics as much as possible. So that's something that you can control for when you're designing. And then when you're analyzing, you can control through using different statistical adjustments. So age is one thing that tends to impact a lot of association. So you can adjust for age if you know that a population is specifically younger than the other population when you adjust for it. So you're kind of controlling for it. So you know that the outcome that you see or the association you see will not be because of age. So there's like the simple age adjustment, or you can do like standardized ratios. And you've probably seen that in a lot of studies where the outcome is always age adjusted odds ratio, for example. And another thing in the analysis that you can do is you can stratify by different groups. So you're kind of comparing within subgroups, and that also gives you an indication of sometimes there's like a specific group that's masked in the overall odds ratio, for example. So if you stratify them by different groups, I'll give you an understanding of their risk within those groups and how if they vary, then you know that there's another variable that might be impacting it. So I hope that's helpful.
Thank you. Thank you. And I'm just responding. So Amanda, we'll have to get the chat function for you. Some people have responded to your comment about grain-free dog food. So, and even using examples of a case study. So there we go. Marriage of two different worlds. One of the last questions is, one issue with observational studies is frequent dueling studies. Example, coffee drinking is associated with every possible issue, positively, negatively, same thing probably for red wine. How should clinicians discuss this issue with concerned patients?
Yeah, great question, really thoughtful audience. And I guess that brings me back to the importance of the research question. So I think it's really context specific. I know in some cases, maybe a little bit of coffee in the morning is supposed to be really good for you, but if you have, more than 6 cups a day, that's too much. So I guess I would suggest looking at what the specific research question is. Is this about a youth who's experiencing a lot of anxiety because of being home during COVID and not participating with their peer groups? Maybe coffee would be something that would be making that anxiety heightened. So that's why I say context is really important. And in another case, when a parent is up all night and needs to be fueled a bit, maybe the coffee is the answer. So I'm just trying to make a little joke, but I think the answer is it's context specific.
And probably there's a difference between causality and association, right, with respect to observational studies as well. Well, I wanted to wrap this up. I mean, I think there's been a very active chat function or chat box discussion, and thanks very much. And people have been adding in links to different tools and different methods of appraisals and different other scales that people are interested in. So thanks very much. That people have been asking about specific tools. We'll figure out a way to answer some of those questions as well. So I just wanted to bring this session to a close, and a really big thank you to both Amanda and Sahar for their great presentations, and Amanda's family for providing us with examples. Your dinner table conversations must be fantastic. They'll be back in 1 week to wrap up the series. I think we all agreed on a COVID question. The final session will be much more interactive, and among other things, we'll look at how observational studies can provide context on gender and other important issues. Please fill out the short evaluation survey that you'll receive after today's session. Keep an eye out for the CADIS website on information on upcoming events. And until then, we will see you next week. And please take care of yourself, wash your hands, wear a mask, and stay safe. Thanks so much.
Thank you.